Hello everyone, happy evening, a very good evening. I hope and I believe all of you are doing well. Yes, am I audible and visible? A quick note before we start with the session. All right, that's great. So, guys, remember that it's just maybe just one more day for the D day, and remember whatever hard work, whatever efforts you have put in will definitely give you the sweet fruits. So, have that faith in yourself, have that faith in the supernatural power, and stay calm. Okay, that is very, very important because until and unless you maintain your calm, nothing is going to work. All the hard work that you have done so far will go in vain. So remember, the most important thing is to maintain calm. So I've also published a video, posted a video today on this channel itself on how you should not get panicked, how you should avoid a panic attack, and if at all you get a panic attack, then how you should face it. Also, please watch the yesterday's video where I've talked about the last days stress and anxiety that we get, why it is not worth it at all. Okay. So thank you so much, Prakhar, for those kind words. Thank you so much. So even in the today's session, we are going to learn some quick mnemonics on porphyria. My target is to help you quickly revise this topic of porphyria. We've already done biochemistry, mnemonics in 3 parts, pharmacology in 3 parts, and many others. So to make sure that all of you have your circadian rhythm right and your concentration right, to help you assess that you are well awake in the morning, tomorrow, rather than having a class at 5 p.m., that is evening, I have scheduled a class for tomorrow 8:30 a.m. It's gonna be your radiology mega rapid fire revision. Like if I would have done for my exam just one day before the exam, how I would have revised radiology. That is what exactly I'm going to do with you all tomorrow 8:30 a.m. So that will help you to assess whether you are able to wake up early, you are able to maintain your concentration. So this is like going to be rehearsal. Of course, not 3.5 hours. It's gonna be 1 hour or so. Okay. So Mohini, it actually depends on your personality. It varies from person to person, whether you want to study or you do not want to study. If I tell you about myself, I am a kind of person who keeps studying till I enter into the examination hall. If you have been throughout your lifetime a person who likes to stay calm, just relax one day before the exam, follow that. Whatever suits you the best, please follow that. Tomorrow's 8:30 a.m. class is on the app. Okay, not on the YouTube channel, it's on the app. If asked for a code to join, use the code Dr. Nikita Life. All right. Okay. And before I start with this, plus subscribers, please make the best of whatever courses are available. If you're not understanding anything, at least revise the mnemonics that we have discussed in the various sessions that we have had. And a special class, if you want, if you have any other queries, today 5 p.m. I already discussed the exam hall strategy, the cheat codes that will come to your rescue to help you score more. Please watch that session, very, very important. If you have still more queries, you can ask me tomorrow 8:30 a.m. Okay. Or after that, just a quick update for the FMG students and next 2022 students. You have a new batch starting on 8th September, so make the best of it. All right. Now, starting with the topic of porphyria, so basically there are 8 types that we have. Okay, so there are basically 8 types: 1, 2, 3, 4, 5, 6, and 7, 8. Okay, there are 8 types of porphyria. You need to know what is the enzyme deficient, what are the clinical manifestations, which is autosomal dominant, which is autosomal recessive, and some unique features of porphyrias for each type. Okay. Now, what is the rate limiting step for heme synthesis? Is basically the first step, which is ALA synthase. Remember, that's the rate limiting. The amino acid is glycine, which is required, and you have succinyl CoA. What is the vitamin which is required here, guys? What is the vitamin? It is pyridoxal phosphate. Okay, remember, it is pyridoxal phosphate. So the first step is ALA synthase, which forms your ALA. Then after ALA, you get ALA dehydratase, which forms porphobilinogen. Then porphobilinogen gets porphobilinogen deaminase. That is basically your HMB synthase because it forms HMB, hydroxymethylbilane synthase. Now this HMB by non-enzymatic process is converted to uroporphyrin 1. So can I say that PBG deaminase or HMB synthase is also uroporphyrinogen 1 synthase? Okay, it is uroporphyrinogen 1 synthase. Then you have uroporphyrinogen 3. Now remember that in porphyrins, first is U, then is C, and then is your P. So like you have UCB, the brand United Colors of Benetton. Remember it is UCP rather than B, it is P. So पहले आएगा यूरो, फिर आएगा कॉप्रो और फिर आएगा प्रोटो. So you will have your protoporphyria either in the beginning or at the end, as we will see later on. Okay. So erythropoietic protoporphyria is the last one. It is erythropoietic, मतलब RBC वाले stage पे पहुंच गए हैं last में. Okay. Now remember, so first is uroporphyrinogen 3 synthase. Then from uroporphyrinogen you have to form copro, and from copro you have to form proto. So uro decarboxylase is what forms copro, and copro oxidase is what forms protoporphyrinogen, and then the protoporphyrinogen oxidase forms protoporphyrin. So basically remember, it is the decarboxylase enzyme which forms the copro, and you have oxidase. And then finally it is protoporphyrin 9 which has ferrochelatase. Iron is incorporated and heme is formed. Now heme has iron in which state? Is it the ferrous state or is it the ferric state? Remember, it is the ferrous state, right? It is the ferrous state. Okay. Now the tricks to remember here, important as I said, remember it is UCP, like UCB. First euro, then copro, and then comes proto. So the euro ones, पहले वाले जो हैं आपके, you will see them coming first in the pathway. All right. Now, out of the 8 porphyrias, which are autosomal dominant and which are autosomal recessive? The first one, which is your ALS synthase ka problem, ALS synthase, that leads to X-linked protoporphyria. Okay, that leads to X-linked protoporphyria. And which is that? Is it a gain of function or is it the loss of function of ALS synthase? Is it gain of function or is it loss of function? Very good. So remember, it's the gain of function mutation in ALS synthase 1 or ALS synthase 2. Remember, it is ALS synthase 2. So that is X-linked protoporphyria. Remember, the first and the last one, they are protoporphyria. X-linked and erythropoietic protoporphyria. The last enzyme, ferrochelatase, this comes in the last. Heme formation, heme is erythropoietic. आखिरी में it is protoporphyria, not uroporphyria or coproporphyria. It is protoporphyria. So all your erythro wala are autosomal recessive, like erythropoietic protoporphyria, congenital erythropoietic porphyria, and your ALA dehydratase wala. ALA dehydratase AD is a misnomer. Remember, it's not autosomal dominant, it is autosomal recessive. And X-linked is X-linked. Remember that out of 8 porphyrias, 4 are autosomal dominant, 4 are not autosomal dominant. 3 out of that are autosomal recessive and 1 is X-linked. Autosomal recessive AR is ER, the erythropoietic wala. So you have erythropoietic protoporphyria, congenital erythropoietic porphyria, misnomer ALA dehydratase porphyria, and you have X-linked, which is due to ALA synthase. The rest of them, जो बाकी बच गए, AIP, okay, with the rest of them, acute intermittent porphyria, then your porphyria cutanea tarda, coproporphyria, varigate porphyria, all are autosomal dominant. The trick to remember is that erythropoietic is autosomal recessive. Autosomal dominant is not ALA dehydratase, it is autosomal recessive, and you have X-linked. Very, very important to remember this. Now the other important points. Heme synthesis, does it occur in the cytoplasm or does it occur in the mitochondria? Heme synthesis, heme, we hug with both the arms, heme, urea, gluconeogenesis. So heme is both mitochondria and cytoplasm. So out of these 8 enzymes, the first one is mitochondria, the next 4 is cytosol, and the last 3 is mitochondria again. So remember, we start with mitochondria, then is cytoplasm, and then is mitochondria again. So if asked about ALA synthase, remember it's a mitochondrial enzyme. The last 3 are mitochondrial enzyme again. Okay. After that, coming to the next point that you need to know here, acute intermittent porphyria is due to deficiency of. Remember AIP. I is like 1. It is uroporphyrinogen. 1 is 1. Roman 1 is I. Uroporphyrinogen 1 synthase. It is uroporphyrinogen 1 synthase. Uroporphyrinogen 1 spontaneously forms. So it is also your enzyme HMB synthase or PBG deaminase. Remember, they are the same. PBG deaminase or HMB synthase. Uroporphyrinogen 3 synthase. Remember 3, the third alphabet C. It is congenital erythropoietic porphyria. Okay. 3 is congenital erythropoietic porphyria. Congenital wala. Okay. Congenital means since birth there will be lesions. Alright. After that, the next enzyme is your uroporphyrinogen decarboxylase. We know that after uroporphyrinogen, it forms your coproporphyrinogen. The porphyria which occurs due to that is porphyria cutanea tarda. So remember, cutanea tarda is C wala enzyme decarboxylase. It is decarboxylase wala uroporphyrinogen decarboxylase. It is the most common porphyria in adults. Classical image, over the dorsum of hands you get blistering skin lesions. It is cutanea, so it has cutaneous manifestations. Alright. What is hepatoerythropoietic porphyria? Remember, it is the autosomal recessive form of porphyria cutanea tarda. It is the autosomal recessive form. Then you have hereditary coproporphyria. That means coproporphyrin is going. So there's a problem in coproporphyrinogen oxidase. Then you have variegate. Variegate, the alphabet V comes at the end. So the problem is with which porphyria? End wala porphyrin, that is protoporphyrin. So the enzyme is protoporphyrinogen oxidase. Last में it is erythropoietic protoporphyria. So again it is basically protoporphyrin. So end wala it is erythropoietic, that means heme wala problem, ferrochelatase. Remember, that is ferrochelatase. So do not get confused with congenital erythropoietic porphyria and erythropoietic protoporphyria. What is the enzyme in congenital? C is third, uroporphyrinogen 3 synthase. Erythropoietic protoporphyria, protoporphyrin at the end, erythropoietic iron not coming, it is ferrochelatase. Okay, so which is basically heme synthase. Heme is not getting formed, so it is heme synthase. Okay, it is heme synthase. Okay, is this clear with everyone? Right? So remember that mitochondrial is first and the last 3 और बीच के जो 4 है वो है cytoplasmic, and these are the enzymes deficient. These are the enzymes deficient. So AIP is uroporphyrinogen 1 synthase, porphyria cutanea tarda, C is decarboxylase uro, and variegate, V is at the last. It's the problem with protoporphyrinogen oxidase, okay, which is not forming protoporphyrin. All right. Out of that, which are the enzymes which are inhibited by lead? Lead inhibits ALA dehydratase and it inhibits ferrochelatase. Okay, it inhibits ferrochelatase. So because of that, it is basically increasing the action of ALA synthase because heme is not getting formed, porphyrin is not getting formed. So feedback say ALA synthase will increase. So remember, if the question is कौन सा increase हो रहा है, it is ALA synthase. Dehydratase and ferrochelatase are inhibited. What is the classical history that you get in lead poisoning? You will have a patient who is living in an old home. That means old paint hai, paint, wall paint, eating ka history hai. Okay, there is anemia, pallor is there, colic is there, abdominal colic. All those are the features that you will have, right? Remember the mnemonic A, B, C, D, E, F, G for lead poisoning. There is saturnine gout, which is there, foot drop can occur, encephalopathy, colic constipation can occur, basophilic stippling can occur, right? There can be anemia, pallor can be there. All of this will be the features. Now going to the next one, okay, I hope all of you are clear with the enzyme deficient. X-linked is ALA synthase, ADP is ALA dehydratase, AIP is uroporphyrinogen 1, which is HMB synthase, which is porphobilinogen deaminase, congenital is uro 3, PCT is uro D carboxylase, coproporphyria is coprooxidase, variegate is protooxidase, and EPP is ferrochelatase. Out of these, which is autosomal recessive? Erythrovala. This is autosomal recessive. This is autosomal recessive. AD is autosomal recessive, and X-linked is X-linked, right? Now coming to which is neurovisceral symptoms and which is cutaneous symptoms, okay? Now, the trick to remember whether your porphyria has neurovisceral, whether it has cutaneous, or it has both the symptoms, okay, or it has both the symptoms. So remember, all your erythrovala is your cutaneous, okay, all erythro is cutaneous, plus जिसके नाम में क्यूटेनिया आता है porphyria, cutania, tarda. This is cutaneous only. Now, which is the erythrovala? Erythropoietic protoporphyria, congenital erythropoietic porphyria, and the other protoporphyria, which is X-linked protoporphyria. Okay. So remember, all erythro are basically autosomal recessive, which are there. So EPP, CEP, and proto-XLP, right? Which are the ones which are both neurovisceral and cutaneous? Remember, both matlab combined. Combined is your copro. Combined is copro, C for copro, and variegate. So when you write V, so you are telling like there are two features, 1 and 2. So it is cutaneous also and it is neurovisceral also. So remember, copro and variegate are both. The rest which are remaining two, AIP and ADP. Okay, AIP and ADP are neurovisceral only. Okay, they are neurovisceral only. They do not have your cutaneous manifestations. So remember, neurovisceral, like your acute symptoms, acute abdominal pain, acute psychiatric. So the acute ones, AA acute करके याद रखो. Neurovisceral acute attacks, they are only neurovisceral, AIP and ADP. Okay, AIP and ADP. Very, very important that AIP does not have cutaneous manifestations. Okay, remember that AIP does not have cutaneous manifestations, right? So let us complete the table here. X-linked protoporphyria, cutaneous. ADP, AIP, neurovisceral. Erythropoietic is cutaneous. Cutania tarda, cutaneous. C, combined copro and variegate is both. It is NV plus cutaneous, NV plus cutaneous. Erythropoietic again is cutaneous. Okay, is this clear with everyone? Right? Now coming to the other unique features that you should know. Porphyria cutania tarda, classically dorsum of hands with blistering lesions, right? Let me show you the other table. Which are the hepatic porphyrias, which are erythropoietic? Erythro are autosomal recessive or your X-linked. Congenital erythropoietic porphyria, erythropoietic protoporphyria, and X-linked protoporphyria. These are erythropoietic. The rest of the 5 are hepatic porphyrias. Okay. So all erythropoietic are not autosomal dominant. All hepatic are autosomal dominant except one. कौन सा देखा हमने misnomer है? ALA dehydratase वाला. ALA dehydratase is autosomal recessive. Then we also saw that your AIP and ADP are neurovisceral only. They are neurovisceral only. Cutanea tarda is only cutaneous. Copro and variegate combined and V is both. And all erythropoietic are only cutaneous. Okay, this is what you need to know. Now, this is again we have seen, whenever you see that porphobilinogen is increased, it is AIP. In ADP, there will be normal porphobilinogen, right? Why am I telling you this is, suppose they give you a patient with acute abdominal pain, psychiatric features, tachycardia, and there is no cutaneous. So you think of AIP or ADP. How will you differentiate between the two is, in AIP, the PBG levels will be increased because PBG deaminase नहीं हो रहा है. यहाँ पे the PBG levels will be normal. That is how you will differentiate the two. So PBG increased is AIP. Okay. Now look at this one. Okay, look at this table. In your cutaneous manifestations, blistering and non-blistering, which are the ones which are non-blistering? Remember proto. जहाँ प्रोटोपोर्फायरिया है वो नॉन ब्लिस्टरिंग है. तो X-linked protoporphyria और erythropoietic protoporphyria, these are non-blistering. The rest which have cutaneous are blistering skin lesions. Okay, these two are non-blistering. Can you tell me which one has hemolytic anemia? Which one presents with hemolytic anemia? Which one presents with hemolytic anemia? Hemolytic means erythro. कौन सा वाला? Congenital erythropoietic porphyria. Okay, remember CEP. Hemolytic anemia, so it can also present with hydrops fetalis. It can cause hydrops fetalis. CEP is also called as Gunther's disease. And remember, erythropoietic porphyria, it can lead to your erythrodontia. The red color in the teeth, that is erythrodontia. So remember, erythrodontia, erythropoietic porphyria, not erythropoietic protoporphyria. Next important point, which porphyria has a unique feature of showing fluorescence under ultraviolet light? Fluorescence रहेगा, unique fluorescence. Remember, it is variegate. Okay, it is variegate. So variegate is various. That means it is different from the rest by showing this unique fluorescence. By showing this unique fluorescence. All right. Let us see some questions. Look at this image. What do you think is the diagnosis here? What do you think is the diagnosis here? Dorsum of hands, the scarring that you see here, that is Porphyria cutanea tarda. What is the enzyme deficient? It is decarboxylase, uroporphyrinogen decarboxylase. Remember, Porphyria cutanea tarda is associated with hepatic disorders, right? Hepatic disorders, it can be sporadic, very common. It is sporadic. Others are inherited. This can be sporadic as well. Okay. Next one, what do you think will be the answer to this? Acute intermittent porphyria is due to deficiency of. Acute intermittent porphyria is due to deficiency of. Remember, A, I, P. I is 1. Absolutely right. So this is uroporphyrinogen 1 synthase. Uroporphyrinogen 3 synthase. 3 is congenital erythropoietic. What does ferrochelatase lead to? Last wala protoporphyria, erythropoietic protoporphyria. ALS synthase first one, X-linked protoporphyria, right? And remember, protoporphyrias are non-blistering. Protoporphyrias are non-blistering. Okay. Next one. Which of the following is not inherited in an autosomal dominant mode? Which of these is not autosomal dominant? The question is not inherited in autosomal dominant mode. Absolutely right. Remember, erythropoietic. Erythro ER is AR. So that is autosomal recessive. Okay. The rest are autosomal dominant. Next, look at this question. What do you think will be the answer to this? So a lengthy question, this is how you can get on these simple topics like this, which seems like very memory or fact based. You can get clinical scenarios like this. Very good. So majority of you have answered it correctly. Whenever you get a question on diagnose the type of porphyria, how you need to approach this is always look for what are the features. Is it cutaneous, is it neurovisceral, or is it both? That will help you rule out the options. Now you have blistering skin lesions and there is no abdominal or neuropsychiatric. That means this is cutaneous only, right? Look at the option coproporphyria, variegate porphyria. These are both. So this is out. AIP is neurovisceral. So this is out. So it is porphyria cutanea tarda. It is cutaneous only. The blistering skin lesions. Right? So this will help you solve the question. Always look for this very, very important. Cutaneous, neurovisceral or both. That is why it is important to know that mnemonic C and V combined and V, they are both, okay, and AIP, ADP are neurovisceral only. The rest of them are cutaneous. Erythropoietic are cutaneous, cutanea tarda is cutaneous, right? And remember, this is blistering. So which porphyria is ruled out? The protoporphyrias are ruled out, okay? The erythropoietic protoporphyria, X-linked protoporphyria is also ruled out here, okay? That is also ruled out. Baki, I have not even seen anything else in the question. Based on this only, we can solve the question. Okay, based on this only, you can solve. Next one, porphyrias absorb light in which wavelength? A fact-based question. It is 400 nanometers, which is something called as Sorette band. So at the 400 nanometers, you see this absorption. Sorette band is seen. Okay, 400. After that, quick points, porphyria cutanea tarda. It is blistering on the dorsal surface of hands. Associated liver disease will be seen. Liver disease important. That is why you have the autosomal recessive form also, which is hepatoerythropoietic porphyria. Okay, so hepatoerythropoietic porphyria is autosomal recessive form of porphyria cutanea tarda. Gene located on X chromosome is ALA synthase 2, not ALA synthase 1. AIP will classically have abdominal crisis, generally young women, occipitals vagera. Nervous system, it is neurovisceral. There can be hyponatremia, and remember there is porphobilinogen which is elevated, very important. Variegate porphyria, classically unique fluorescence peak at neutral pH. That is very, very important. Remember the test for porphyria that you have? We have Ehrlich test, Watson-Schwartz test and the Sorette band at 400 nanometers. Ehrlich, Watson-Schwartz and Sorette band. That is what we have. Okay. Gunther's disease dekha. CEP is also called Gunther's. It is autosomal recessive erythropoietic uroporphyrinogen 3 synthase. Hemolytic anemia is there. Congenital, so from birth. And classically, it is deposited in teeth and bones. And it can lead to non-immune hydrops. That is hemolytic anemia. Okay, that is hemolytic anemia. So, that is the quick revision of your porphyria. Any queries here, guys? Any queries? This is the table that you have for revision, which is autosomal recessive, ALA dehydratase, misnomer. Uroporphyrinogen 3 synthase, that is erythropoietic. Then you have hepatoerythropoietic, which is autosomal recessive of PCT. Then you have erythropoietic protoporphyria. X-linked is first one. Okay. AIP is due to porphobilinogen deaminase, that is uroporphyrinogen 1 synthase. Cutanea tarda is decarboxylase. Variegate is protoporphyrinogen oxidase. Neurovisceral only is AIP and ADP. AIP and ADP. Both is copro and your variegate porphyria, right? It is copro and variegate, which is both. The rest is cutaneous only. Even in that, the protoporphyrias are non-blistering. Okay, the protoporphyrias are non-blistering. Congenital erythropoietic porphyria will have hemolytic anemia. will have erythrodontia. It will have erythrodontia. Okay, right? Hepatoerythropoietic porphyria, Dr. Grace, it is the autosomal recessive form of your Porphyria cutaneatada, uroporphyrinogen decarboxylase, right? The same enzyme like your PCT, but it is the autosomal recessive form. Okay, so that was about the topic of porphyrias. You only need to know the enzyme, you need to know the inheritance pattern, and you need to know the clinical manifestations. Okay, you have the mnemonics in hand for everyone. I hope this is clear with everyone and this helps you in the last minute revision of this topic. So we are meeting for the final time tomorrow at 8:30 a.m. guys, on the app Radiology Mega Rapid Revision. Like one day before the exam, what you should be doing in radiology, wo karenge to give you a rehearsal of the morning time of exam. So 8:30 a.m. on the app Radiology Mega Revision. The code to join is Dr. Nikita Live, and then if time permits, I will also upload a video of urea cycle disorders. Okay, so I'm planning to do that, though I do not promise it, but I'll definitely try and do that. Okay, so thank you so much everyone. Just maintain your calm, stay calm, and everything will be in place. It is time to get the fruits of all the hard work that you have done so far. So stay calm and rock it. Let's crack it, and all the very best. Keep studying, keep revising, and keep winning. Do watch the today's 5 p.m. class that we had on the exam hall tips and tricks, the cheat codes to get the answers right. All right. Goodbye and good night. Thank you.